Okay. Good evening, everybody. My name is Bethany. I'm a registered respiratory therapist, graduated from Pima Medical Institute, Britain, Washington, in 2014. My vision is to aspire to help as many people be able to inspire easily. Breathe easy, everybody. What is asthma and what does it affect? What do you guys think of when you hear somebody say asthma, asthma exacerbation? What do you think of? Difficulty breathing? Maybe it's like a horse on your chest? Think of it this way. People that have asthma, it's almost like they're breathing through a straw. Okay, that's how difficult it can be. What it involves is the respiratory tract. You have your lungs, your bronchial tubes, which are the passageways for air to come in and outside of your lungs, okay? Airways that become inflamed due to hypersensitivity. It could be because of bronchitis. It could be due to allergies, many different things. If you look at the three pictures on the top here, on the very last picture, do you see how the smooth muscle that is wrapped around the bronchial tube is constricted? And you can see how the middle of the airway is almost closed, isn't it? That is because there are mast cells that are around the inside of that airway that secrete mucus. And an overproduction of the sticky mucus along with the bronchoconstriction of the airway is what asthma is all about. They can hardly get air in, and then they trap it once it's in their chest and they can't exhale it out. So there's many different classifications of asthma. You have intermittent asthma, which is when a patient experiences the symptoms of wheeziness, shortness of breath, or coughing, but they don't need the treatment, okay? They can do pretty much normal activities. It doesn't really interfere much with it. And as far as symptoms at night, the nocturnal symptoms when you sleep is about 2 days a month or less, okay? And then as you go down, you see it's mild, persistent, moderate, and severe. With the mild persistent, you have symptoms that occur more than twice a week, and the attacks do interfere with daily activities, okay? So you might have to modify your daily activities. And the nocturnal symptoms are present at least 3 to 4 times a month. Okay, and then moderate persistent, the symptoms are almost every day, and therefore your daily activities must be modified, okay? Your nocturnal symptoms are present more than once a week, and so it will have to be controlled by medication. The severe persistent is you have symptoms every day, okay? Your activities are modified to the point to where you may not be able to do them, period, okay? Nocturnal symptoms occur very often with severe persistent asthma, and they classify it by either previously having life-threatening exacerbations or being hospitalized more than 2 to 3 times the past year. Okay, so you can tell that from intermittent to severe, a person can have intermittent asthma and go to severe very quickly. So what are the triggers of asthma? What causes it? Well, you have allergic or non-allergic asthma, okay? People who have allergies, seasonal allergies, or The non-allergic could be people that just have the symptoms. Maybe they're at work and there's mold at work, that's non-allergic. You have aspirin induced, like my mom, she's allergic to aspirin, she can't take it. If she takes it or they give it to her, then she's going to have respiratory issues. Exercise induced, that happens when the air temperature changes all of a sudden. Maybe you're a mouth breather when you're running, okay? The difference in temperature can exacerbate the airways, cause a lot of secretions in the airways, and therefore they're going to cough, okay? Hypersensitive airways. Cough variant, that's usually a dry cough, somebody that's constantly coughing and coughing and coughing and can't cough anything up. Work-related, just like working at the plant, people are exposed to many different chemicals. A lot of people don't wear their HEPA filters, and so they're constantly breathing in product. We discussed the nocturnal or nighttime. This usually happens in the evening before bed, and it's like clockwork. The patient will start to get wheezy, coughing a lot, and then just asthma due to obesity. That plays a big role. Somebody who is very overweight, they try to exercise or walk from point A to point B and they start wheezing. So that has a lot to do with what triggers asthma in many of the individuals that we see. So signs and symptoms of asthma: frequent coughing. You can have shortness of breath, which is what we call dyspnea. Nasal flaring, when your nerves are flaring. Accessory muscle use, where we will see retractions in the torso of somebody who's really struggling to breathe. Okay. Chest pain, it can cause chest pain where people think they're actually having a heart attack. Inspiratory and expiratory wheezing. You'll hear wheezes when they're breathing in, and you may hear crackles and wheezes when they're breathing out, and that's through all of that sticky mucus that's in their airways. If you stop hearing the wheezing, you might think, oh, they're cured, they're better, they're not as bad. They're critical. If they stop wheezing on inspiratory or expiratory, they are having a hard time breathing because their airways are closing, okay? It is an obstructive disease, more so than restrictive, because of the inflammation of the airways, they will close. Increased mucus production, and then you have the tripod position. Rebecca, you ought to know what that is. Mm-hmm. So tripod position is when they're standing like this, it's easier for them to get air in and air out, okay? That is why many times people who are in respiratory distress, you will see them either sitting in a chair with their hands on their knees, or they will be bending over like a runner who just got done running a mile. They need to catch their breath. Fatigue and mood behavior changes due to lack of oxygen to the brain. Okay, so it can cause panic. It can cause anxiety because they can't breathe, they can't catch their breath. And then, you may notice cyanosis, which is blueness around the lips due to lack of oxygen. Numbness and tingling in the hands. So there are different signs and symptoms that you can look at and understand that maybe that person is actually in crisis. So what information is really needed for your physician or respiratory therapist to possibly give you an asthma diagnosis? They're going to ask for your personal history. Your personal history needs to be allergies, any illnesses that you've had ever, surgeries, immunizations, and any testing or screenings that you've had in the past year, 2 years. This will tell them a lot about your past medical history So they can make these differential diagnoses and hopefully come to a conclusion and get you the help that you need. Another thing that they will talk to you about is your family medical history. You should know your family's medical history 3 generations back. It's important that you know what your grandparents died of. Does asthma or any type of chronic respiratory illness run in your family? What about heart disease? What about COPD? That's chronic obstructive disease. Okay. Surgeries, any chronic or terminal conditions. So, with that being said, how do you assess a patient? Well, we do a physical assessment, right? We have to listen to your lungs, which is lung auscultation. This is where we take our stethoscope, we'll listen to your lungs in the front and in the back. We will check your ears, nose, throat, skin, and chest. Is your skin hot and dry? Are you pale, cool, or diaphoretic, which means shocky? Your sinus and chest x-ray, perhaps. Sinusitis can cause asthma. Chest x-ray will show if your lungs are hyperinflated. That is another way that they can tell if you're air trapping, if you're, asthmatic. And then there's the blood gas. That is for really severe exacerbations of asthma. And what we check with a blood gas is your pH balance, your carbon dioxide, and your oxygen. And we can tell if you are going to be alkalinic, acidic, or if you're pretty normal. So we will take it through an artery. It is a blood draw through an artery. So we will check your wrists, and that is how we draw. We can also do pulmonary function testing, or PFT. We have spirometry, which measures how fast and how much air you breathe out. Okay, that's an actual spirometry machine that we do use to test. We have a peak flow meter, pheno testing, which is exhaled nitric oxide. And what that is it tests the inflammation of your airways. So if your airways are really inflamed, you will exhale nitric oxide and they will be able to measure it to see how inflamed. And then the methacholine challenge. So with the methacholine challenge, they have you inhale an aerosol, okay? And if your airways are reactive, we know that you possibly have asthma, okay? If they are non-reactive, asthma is probably not going to be your diagnosis. So that is some ways that we assess patients for an asthma, diagnosis. Another is a chest x-ray. So can you see asthma on a chest x-ray? It's really hard, okay? Typically an x-ray is used to see your heart, your blood vessels, your lungs. And what we can see to help diagnose is you can see on the x-ray, you see how the heart, I need to go actually move. And so I'm just gonna come up here. If you look right here, you can see that the heart is elongated, okay? That is one way that we can tell that the patient possibly has asthma. Their diaphragm is flattened, okay? And if you look down here, you can see more ribs, okay? So he is very barrel chested, so he's air trapping. That's an increased AP diameter, which is anterior posterior. So that means that the patient is very wide through in here because he can't exhale the air. He can't get it out. Okay, so that is one thing that we can tell by an x-ray. It's not so much as seeing asthma, but we can see how many ribs and the diaphragm and the heart. So treatments and interventions. So short-term medications, of course, your albuterol, okay? Albuterol, levalbuterol or Zopanex, metoprolol, terbutaline, and salmeterol or Ceravent are all inhaled medications for asthma, okay, for short-term. Long-term control medications are your inhaled corticosteroids, which are given for anti-inflammatory of the airways, okay? Sometimes they will use it in combination with what they call LABAs, which is long-acting beta agonists. And what those do is those simulate the muscles around your airways to relax so you can breathe, okay? They will also give sometimes theophylline. Theophylline is a really, it's like caffeine, okay? Caffeine is a bronchodilator, or a vasodilator. So theophylline contains a chemical really similar to caffeine, but it's a weak medication. I do want to tell you, anytime a physician or respiratory therapist gives you an inhaled corticosteroid, make sure you rinse your mouth out after you take the dose, because with the inhaled corticosteroid, you can develop a yeast infection in your mouth called Candidus, okay? So it's really important that you rinse your mouth out after a steroid. And then, of course, for adults, we have what we call Duoneb, which is albuterol, the fast-acting bronchodilator, and ipratropium bromide, which is a slower-acting muscle relaxant. And we give those nebulized, or they can be inhaled through an inhaler. So interventions, non-invasive is what we go for versus invasive. So we will put a patient on a BiPAP or bi-level positive airway pressure machine. This machine will deliver higher pressures when you're inhaling, because that's normal. It's higher pressures when we inhale versus when we exhale. We will put you on a BiPAP because it's easier for you to exhale versus being put on continuous positive airway pressure, which means you have to fight that higher pressure to exhale. Okay. Invasive ventilation, the patient will buy an endotracheal tube. The tube is placed and the patient is placed on a ventilator with a dialed-in tidal volume appropriate for the patient's body weight and height. And then we can deliver the appropriate amount of tidal volume for the patient so they can be oxygenated. So patient care planning is really important. Proactive home measures that you want to do, use an air purifier in your home. Make sure you don't smoke in the house. If you smoke, put a raincoat on, go outside, have your cigarette, take your raincoat off before you come back in the house and go wash your hands. That way the smoke does not get on your clothes and your grandbabies or your children aren't breathing in. Wash your bedding every week. Mold and dampness in the house can trigger it. Pay attention to air quality, especially here in the desert with the high winds. You get the dust from Owens Lake blowing over here. You hear people say, stay in your house. There's a reason for that, because it can exacerbate anybody with a chronic respiratory disease, okay? And manage your seasonal allergies. That's really important. So peak flow testing is one way that we can monitor if you are doing okay with your asthma or if you need extra control with your asthma, extra maintenance medications or whatnot. So this just goes through and lets you know that when you are peak flow testing, you want to stand up straight. You want to make sure that you have the device in your mouth with a tight seal. You're going to blow out as hard and as fast as you possibly can, and you're going to write down that number in a log. It's imperative to keep track of this number in your log because your physician is going to need these readings. After you're done, you move the marker back to the bottom and you do this 2 more times. The highest of the 3 numbers is your peak flow number, okay? It's really important that you're consistent with that. So for you school teachers in here, this is an asthma action plan. Every student that is diagnosed with asthma ought to have one, okay? This gives you pertinent information on what you need to do in case your student is having an asthma exacerbation, okay? So in order for them to have their personal best peak flow numbers, they need to have taken it at least 2 times a day for a 3-week period, before and after taking their quick relief medication, okay? When you get a new peak flow meter, you want to take your peak flow anyways, even if it's the same meter, because it may not register the same as your previous meter. You need these numbers because your physician or the patient's physician is going to write the peak flow numbers under the green, the yellow, and the red. And it's exactly what you see. If your child's peak flow is between the 2 numbers under the green, they're good to go, okay? As you go down to the yellow, you might want to modify some activity and make sure that they've taken the medication. If they take it and their number is in the red, you need to call 911, okay? It's imperative because they are in crisis and they need to have some quick acting medication to be able to open up the airways so they can breathe. So in conclusion of my presentation, the number one thing is take control of your allergies before they take control of you. Make sure that you know what you're allergic to. Take your medication if you're out or you know you're going to be out. Make sure that you call your doctor. Follow your asthma action plan. They're there for a reason. They're there to help you, so you don't end up in the hospital with a severe exacerbation. We don't want that. Locate an asthma support group. The Asthma and Allergy Foundation of America is one website that you can go to that will give you really good information on a support group if you have asthma. In the event of an emergency, call 911. And be like Buddy. And remember your allergy medications for your seasonal allergies. Thanks for your attendance, everybody. I really appreciate it.
Thank you. That was very good. Yeah.